think we could have any easier topic to discuss than caregiving. Having seen Reshmi go through it, and I, of course, have seen it from a distance. So, but having seen it, thankfully, I haven't had a real need to be a caregiver, and I hopefully, it never comes over. But yeah, I think caregiving is the most stressful and more isolate, more very, very lonely journey that it can be, and a very hard one. But also, I think it's something which is, in my view, is not very well understood also. The caregiver's perspective, I have seen my mom being a caregiver when she was a caregiver, and how the burden of expectations used to loom very large on her. And I think in the caregiving journey, one of the common things which happen to a caregiver is they lose themselves along that journey. And I know many of you have been caregivers in the past or are currently caregivers. And I think this was a very important topic to discuss. And, some of you may know that we do also have, these 3 informal caregiver support groups that we run at Silver Talkies. We don't publicize it much. They are very informal in the way that one caregiver kind of passes along the word to another caregiver, and that's how the group keeps becoming bigger. So we have one dedicated caregiver group for caregivers of people with dementia, another one which is for anybody else, any other person other than dementia as an ailment. And then we have passive carers like myself who do not have any active caregiving needs, but then these are kids who have concerns or questions that they may have about their own parents and would like to discuss it in a common group. So yeah, so these are the 3 caregiver groups that we have. Now, let me just very quickly introduce Dr. Debanjan. Of course, he is a consultant geriatric psychiatrist at Apollo Multi-Speciality Hospitals, Kolkata. He completed his MD and DM from NIMHANS, Bangalore, and he specializes in dementia, old age psychiatry, and psychosexual health, with a strong focus on person-centered and community-based dementia care. A prolific researcher and mental health advocate, he serves as deputy co-editor of the Journal of Psychosexual Health. He's associate editor of the Journal of Alzheimer's Disease and also global advisor to the ASEM Global Aging Center. And I think the recent accolade that Dr. Banerjee received, he was, highlighted by Stanford University, top 2% global researchers list by the Stanford University. So heartiest congratulations to you and kudos to you for, always being on top of your research work and helping us out by.
Thank you so much. Thank you, Niti. Thanks for having me here.
Dr. Prem, of course, also has had multiple sessions with us. We've had many sessions with us on, polypharmacy and other topics that we have covered with him. And Dr. Prem is a consultant in geriatric medicine. He has over 14 years of working in the senior healthcare sector in India. He was the first postgraduate in geriatrics from Amrita Institute and further trained at AIIMS New Delhi. And he has led many path-breaking initiatives, which include founding the Jaslok Hospital's first Department of Geriatric Medicine and Senior Support Group. And he's also, his latest initiative, he's also the founding team member and director of medical services at the Wisdom Club, which I will ask him more about, during the course of our conversation. The forum, Reshmi, many of you have known as the co-founder of Silver Talkies. Rashmi, I'm going to add spotlight on you if that's okay. So that she, of course, needs no introduction. She has been the co-founder of Silver Talkies. She also has been a journalist, but most, I think her last few years have been largely being a caregiver. She had been taking care of her parents-in-law. She recently lost her mother-in-law, but she still has a father-in-law, and she also remotely supports her father, who's been diagnosed with dementia and stays away in Gurgaon. So thank you, Reshmi, for agreeing to be part of this conversation and bringing in the perspective of a caregiver. Really appreciate it. Thank you. So this question is for you, Dr. Banerjee and Dr. Prem. What is caregiving? What is the scope of caregiving? What entails caregiving? Can you just briefly explain us?
Thank you, Niti and Reshmi once again. Before we start, I was hearing about you mentioning about various facets of caregiving. Let me make it very clear that whenever I speak at a forum like this, I speak in two roles. I speak as a doctor who works in this field. I also speak as a caregiver because my own father suffers from Parkinson's and dementia. So I am fortunate or unfortunate to have seen how it feels from both sides of the table. And trust me, there are certain things that the other side of the table teaches you that no textbook cannot. So just to start off by mentioning caregiving. See, I would rather, since it's very personal to me, I'd rather think about it as a journey which you never wanted to be a part of, but which you have to be, and sometimes you don't know how long it will last. Uh, of course, this is very much related to dementia care, but I'm sure that caregiving challenges are not just limited to it. I mean, we see individuals with cancer, with chronic illnesses, with rheumatoid arthritis, connective tissue disorders, post serious surgeries. But what makes caregiving for individuals with dementia stand out so much is that you grieve for the person while the person is still very much alive and with you. And that grieving is very, very different. I remember treating patients, uh, telling them all that is necessary professionally, and then coming back at home and then seeing certain behaviors and attitudes of my dad, which of course he was doing because he was not in the right state of mind because of the illness, and he had a rare type of Parkinson's. So I would lose my temper. So no amount of medical training prevented that. And that's what caregiving is about. It's about being you and dealing with the loss of an identity. So the caregiving, it's not just limited to giving medications or taking care of a person's logistics. We know that in India, family is mostly the sole support. But at the same time, we also have paid caregivers, formal caregivers. And I work with ARTSI, Alzheimer's Related Disorders Society of India. We have a Kolkata chapter which is pretty active. So we do take regular training for dementia caregivers because unfortunately, caregiving is something which really, really requires experience, expertise, and empathy. And the last E is very important. I can give medicines to a person, I can take care of him, I can change his or her diaper, I can take him or her out for a walk, but at the same time, I can be very mechanical or I can be really a part of the process or the journey. So if somebody of you are caregiving or whom you know as caregivers, one thing and one primary message that I'd like to start off in this session, and which is my personal theme: take care of yourselves. Because if you are not well, the individual for whom you are taking care of won't be. None of us are superhumans here, and we need care, we need support, of course, which will be discussed later on. But unless we know, we take care of ourselves and we plan. The planning part is most important because this is a war which is going to go on for a long time. And planning just doesn't entail medical planning, social planning, what to do when the illness worsens, legal planning, which is a very, very important part because many times you deal with testamentary capacities and will. So plan, support each other, take care of yourselves, and learn from each other. As a caregiver and as a doctor, I have learned much from caregivers around me than from any of my medical colleagues.
So beautifully put. Thank you, Dr. Banerjee, and thank you for humanizing, the caregiving role completely. I think that's very beautifully put. Dr. Prem, would you like?
I think one of the very important things is to understand that, as Dr. Banerjee told, is that I think everybody is a caregiver. I mean, let's not get into even the medical part. everybody is doing their caregiving in some way or the other. I mean, it's not necessarily that you have to provide caregiving only if a person has a medical condition. Uh, so I think that comes first. And of course, I would put it, it's very well said in Hindi, which I always say is that Swayam Seva fir Sarva Seva. So if you actually take care of yourself, that is when you're able to take care of others. Now, it is very easy to sympathize with people because it comes naturally. Uh, One can say, ki, no, things will be fine. But the word empathy, which again was mentioned, is where I sort of come in from. You have to allow people to understand that you actually are with them in the journey. You're actually empathizing with them and not necessarily saying, oh my God, things are so bad. I mean, having sympathy is very, I mean, it comes naturally. We are human beings, so sympathy should be there. But empathy is what is very important. Then another thing with caregiving, I feel, is there is nothing known as you can only naturally be a caregiver. You can learn skills as well. That's where professional caregivers come in. One thing I would want to highlight is more and more family caregivers should realize that there is professional caregivers. You don't need to do everything. And one very important statistic is maximum amount of caregivers are females. That's a whether and it is people who are working, taking care of their own children, taking care of their own mother and father, taking care of their in-laws, and of course, if the husband is also naughty, then taking care of the husband also. So a lot of times the husband can take care of himself, but I mean, we have different structures throughout. And then balancing that with your own work, which obviously you are not supposed to leave just because you are a caregiver. So that's where I feel to understand, from my perspective, to understand the journey of a caregiver is actually living it with them and to make sure that it's our job as healthcare professionals to give them that knowledge to understand the disease better, or Google and WhatsApp will take over and people will have their own views on caregiving. Uh, for a person to understand that they need help, they need to realize that also. And sometimes being very frank on the face is what is needed to give a reality check that you need to take care of yourself, or it's going to be a very difficult road ahead. Now, let's not only talk about young caregivers. There are a lot of 79, 85, 90-year-olds taking care of 95-year-olds or whatever age. That is not easy at all. And mostly, as I always say, if as a healthcare professional, as a geriatrician, if I'm taking care of the person behind the patient, then I am winning. Because if I'm taking care of them, means I'm taking care of both. And if, on a lighter note, if caregiving was a paid job, all women will be much richer.
Yeah, so true, so true. And in fact, both of you together have brought out so many themes, and I have a lot of questions around all of those themes. So I just wanted to, check that the fact is, of course, caregiving can be needed for anyone in care, and it's irrespective of what that age category could be. But since Silver Talkies work with seniors, I will ask a question specifically with regards to the increasing elderly population that we have, and in exact correlation, it would be the caregiving responsibilities, which would impact all of us, right? And how you said, like, even seniors can be caregivers to the super seniors, and also the fact that there is the fact that the industry is changing, as you mentioned, the professional caregiving side of it. But professional caregiving is also something, it's an emerging sector, but it is also something which is probably available right now in tier one cities, urban cities and all. And also, given the price points at which it comes, it is not available for the masses, right? Now, what is your view on that? Is professional caregiving is something which is it's definitely needed, yes, but is that something which is going to become viable and possible for all caregivers to avail of?
See, as Dr. Prem mentioned, a very important point that affordability, accessibility. and quality. These are the three things we assess in terms of any service. This that I'll tell you now is purely as a caregiver. Individuals who can care for people with dementia or old age conditions or palliative care, even since we have a, Silver Talkies works predominantly for senior citizens, palliative care is also something which is very important. And we need to remember caregiving is not a binary. There are various types of caregiving needs. While some need only assistance to walk, some need just cognitive stimulation, some need logistic help because they are sensory impaired, they probably don't have, hearing issues, vision issues, while some need assistance even to breathe, not to mention diaper needs, insulin, medications, changing of catheter, assistance, mobility. It's a spectrum, a huge spectrum. So the expertise and quality, and of course the affordability, that will also range across the spectrum. First things first, caregiving is a very, very costly affair in India. And I'm not putting down statistics here. We are all tired of webinars and stats. But let me tell you that an average, a very average Indian family who falls in a standard deviation range of Indian population will have very much difficulty in getting a continuous caregiving. A lot of my patients who, they are really burnt out, but they are unable to afford 24 hours care, and hence they take 8 hours or 12 hours. Because as we always say, that caregiving is a full-time profession. And, it's not something that's 5 days, 10 days, 20 days. It can range for months. And if you are talking about dementia, we know that as time progresses, the caregiving needs will only increase. Very rarely they can reduce. And in terms of quality, as I was mentioning right when I started, trained dementia caregivers, they are almost a separate exotic species to be found in India. And I don't see the thing is, what's challenging is you can train a person to change catheters, you can train a person to give insulin injections, you can train a person for Riles tube feeding. What you cannot train a person to do is deal with a person when that person is agitated, to deal with compassion, to deal with empathy, to tell that what you are doing, let me sleep at night, or one of the most important things that I deal with in person. We conduct workshops at multiple places of the world in managing inappropriate sexual behavior in dementia. And that's a very, very challenging area, because in today's world, we know that a lot of individuals, they stay alone. Their children are not there. Either, as Dr. Prem was mentioning, the caregiver is mostly the spouse, be it the husband or the wife. There are CCTVs throughout the house, but probably there are not enough individuals to look at the CCTV and find out what's happening. Because the person who will look into the CCTV is probably, overseas. And when there is a female caregiver assigned or a male caregiver assigned to the opposite gender, which often happens in India because 1:1 caregiver is impossible. If you look at the statistics, it is roughly 1:1200. Imagine. So that's our population, and that's what we have to deal with. No point complaining. But when there is an opposite gender caregiving that's happening, it's a very, very important legal issue, because I have gone to the court several times for testimony about the mental status, the cognitive status of an individual, because the caregiver or the nurse has complained that this person tried to harass my modesty. Let me just give you an example. So this is a very live example, and it just happened a few months back, where a 79-year-old, he's a retired professor. He's from the Jadavpur University, a very learned person of English. And then he developed dementia with some, it's a different type of dementia. Nevertheless, it's been almost a couple of years. His wife has passed away. He stays with a professional caregiver and, another person who kind of comes and goes. The professional caregiver, the male person who looked after him, changed. So a lady actually came, and he has only couple of daughters. Yeah, right, couple of daughters who reside in separate states. So what happened is this lady who was taking care of him one fine day left the job, filed a complaint to the police that he had made some very indecent remarks to her. Things like, why don't you come to bed with me? And it was a huge chaos. It was all over the news. I was tweeting him. There was another geriatrician, diabetologist. All of us were interviewed. The daughters came back. It was almost after few months of this whole ruckus and chaos. What came up was very, very tragic. This individual, due to having a problem with something that is called the parietal lobe of the brain and the frontal lobe, misidentified the caregiver as his wife. And that's exactly the reason. The poor person, he thought that it's my wife whom I'm dealing with, and I have all the right to call my wife to sleep beside me. But then how difficult it is to explain this dilemma to the legal system. And trust me, this was such an embarrassing thing for all of us. And I don't blame the caregiver, because that's what dementia care entails. You need to understand the perspective of the patient you are dealing with. We have to live in their worlds. They won't live in us. Until we learn to live in their world, the caregiving experience and learning is in.
As far as caregiving goes, as I already said, that it's something which one has to teach also. So that's why the human resource is very important. I'll tell you where I'm coming from. So when somebody puts an investment in teaching people how to take care of maybe older adults with or without dementia, or just taking care of older adults, understanding the sensibility. And then, as you said, it is not very cheap to actually even get human resource. Now, the thing is, it's very easy to get cheap human resource. If I'm trying to, I mean, I'm mixing words a bit. It's very easy to get cheap human resource when somebody for a very basic and that person might have just left maybe from his hometown and come to the city and he's a caregiver the next day. That doesn't give me confidence at all. And we always think, am I going to do that for my parent? If the answer is allowed, no, I would not want to do it for anybody else's parent, obviously. So that's where we are. And I know it's the sheer motivation for the younger generation, whether they should get into caregiving. Now, I mean, we have done a lot of work in this and to understand a bit of psychology here. Now we have these 10-minute deliveries. We have Blinkit, we have Zomato, we have Swiggy. So younger generation has been motivated to take gigs because it's good money. They can do multiple gigs. What are we making it lucrative for them to take up caregiving? Now, providing a training is not the most difficult part. Providing a training, after that, making sure they get employment. That is very important thing. And then after that, making sure there is no attrition. That's where you have to take care of them. And usually, let me be very frank, it's not only monetary. A person who is taking care of dementia for 24 hours, 12 hours, maybe in shift, you give him or her n number of amount of money. If the person is very overawed by the situation, it's not going to be helpful. That's where we always prepare more people. We offer them no, that you can take breaks too. See, caregiving is not them actually getting into a jail kind of situation where we are saying, no, you cannot go, only you're going to continuously take care. So my advice usually to caretakers is families is that you always prepare another caregiver in a very subtle way. Maybe have it for 12 hours, make sure that they know. See, another thing I want to highlight. Costly, yes, the best caregiver can come, but the person that is the older adult with dementia might reject. It's not about the fact that the caregiver is bad. It's just about the adjustment has to happen. And it takes time. Imagine for us when we sort of go into a hotel, sleep for one night, maybe elsewhere, we might not get good sleep. So imagine an older adult getting adjusted to a new person completely, maybe after 6 months or 1 year of having a earlier caregiver. So it's very, very important for us to understand that providing caregiving providing training, making sure that they actually get opportunities to care, but they continue and think that this is what we want to do.
Hmm.
Can we reach a situation where a person says, I want to be a caregiver? Is that going to be happening? We have to work very hard for it because, I mean, Dr. Banerjee knows very well, and I know my group of geriatricians know, Silver Talkies knows, a lot of organizations knows the biggest crisis we are going to have is taking care of older adults. We are not going to have, and it's doctors, it's nurses, it's caretakers, it's companions. It's not necessarily that an older adult might need caregiving. Just for going for a movie, do they need a companion? Then there is another thing which has come up now. I mean, having a second, I mean, having intimacy in the later age. Why not? People are actually looking at even developing relationships in later age, and that is something. I mean, why would one want to be alone? So it's a more broader thing. We need more and more people, and we should also tap older adults. The biggest human resource which we never use world over, it's not only India, is actually older adults. Fitter older adults can always be great. They are experienced. And of course, intergenerational bonding also, which also sort of works.
Thank you, Dr. Prem. I think between the two of you, you brought in a lot of practical insights. And I think, yeah, there are different threads to the whole fabric. So, and I think it's very difficult to kind of put it all together. Rash, I would like to bring you in right now, given that you have, been on that caregiving journey. When did you decide, at what point in time did you decide that you needed to get professional caregivers to help you out? And what has that experience been for you?
Well, first of all, what I want to say is, we were extremely lucky to have the resources. What, both of you, both doctors were just talking about. We're extremely lucky, privileged. Thank God that we had the resources to have paid caregiving. At what point, okay, I think working with Silver Talkies for 10 years gave me an understanding of what dementia was. So when it was diagnosed, gradually, initially, I think most of us think that, okay, we will manage. And all of us Indian families, we have trusted helpers also at home sometimes, they'll also say, hum dekh lenge. So yeah, it starts like that. But I think we decided to get in outside help, paid caregiving, when some behavior changes started, which were a little difficult for us to deal with, especially for my father-in-law, this is about, this would have been about 3-4 years back, not even 4, 3 years ago. My father-in-law is almost 90 years old. So you can imagine he was also quite old. So yes, we felt it was time to have help, even though we are a joint family, there are many people. Also, that part which Dr. Debanjan talked about, I mean, not specifically that, but there are so many behavior issues that come up in dementia. My mother-in-law had dementia, which is very hard for people to understand if you haven't been reading about it. Like I said, I was very lucky. I was, doing Silver Talkies for a decade. I had that understanding. I've been listening to experts like them. So definitely had that understanding, but the rest of the family did not. And at that point, it's best if, there is someone taking that burden off you and helping. So
And
that
how
was...
has the experience been, while you've been working with professional caregivers, how has that experience been for you?
Okay, so mixed. In our case, so we had a mix of caregivers at home because we also, apart from dementia, we also had a few age-related health issues with my father-in-law. What Dr. Banerjee said about trained, people with no dementia training, absolutely true. It was easier to get caregivers for, something like, say, my father-in-law had a fall and needed to be bedridden and just needed someone for his daily living activities care. But there's hardly any, you do not get any caregiving where people understand dementia. I got very lucky with Catholic nun-run organization in Pune. Eventually, I got lucky after trial and error for over a year, who actually trained caregivers in dementia, Parkinson's, a lot of progressive disorders. So that was just luck. But otherwise, it is very tough. There are, things like, "Are kha hi nahi rahe hain, unko to abhi nahane nahi jana hai." Even if you explain, it is, there's just no understanding at all. And there's no training that makes them understand this. It is not the caregiver's fault. I think it's the training's fault. And sadly, a lot of well-known services that we hear of do not train their caregivers in this.
Okay. So yeah, so what I'm hearing is, one, it's a matter of luck to be lucky to have, landed with a caregiver who is trained and who has the empathy, as we were all talking about, to be able to empathetic to the the beneficiary needs and to understand what they take. This is a question for Dr. Prem. Dr. Prem, I just wanted to ask, since you were talking about, how I think caregiving, whether professionally done or by a family caregiver, is a very hard job, right? And even though it may be a paid service, eventually those paid caregivers are also human. And as you said, they also will need breaks. So I think my next question to you is that for anyone who is hiring professional help for caregiving, what do they need to keep in mind? What would you tell them that, this is something that you should be mentally prepared for in terms of how do you kind of take care of that professional caregiver also?
Yeah, so I think most families, it's very important to tell them that the caregiver is only going to do these things. I think a lot of time the line is blurred, wherein they're expected to do much more than just caregiving for the older adult. I'm not even saying dementia in general. With dementia, even more, it increases. So, for example, if a caregiver has to take care of a person with dementia who is dependent, then it is everything. It will be for all the activities of daily living, which is taking bath, feeding, cleaning. And on top of that, suddenly you cannot tell them you go and shop for something. I mean, that would not really fit into their particular sort of, uh, even job description, if I have to tell. Another very important thing is communication with the caregiver by the family is very, very important. They have to feel safe. A lot of times it is 24 hours. It is not 12 hours. So they are there. So usually making them comfortable. I mean, by comfortable, I mean in whatever best possible way, because if it is high touch cases, then usually the caregiver hardly gets sleep. And to give them breaks by taking care themselves, whether it's only for 2 hours, 3 hours, or by telling somebody else to do. I think treatment of that particular person, communication with that caregiver is very, very important. Uh, and of course, one of the very important things is to also to tell the proper. So, for example, if I am helping out with some caregiver and I am the company, so to be very good in feedback and not necessarily positive feedback and also reinforcement. Of course, if somebody is doing a bad job, you should highlight it, but highlight it in a professional way and not necessarily in a very unprofessional way, which is going to be a problem on sort of both sides. So I think making them do more than what they should is always kind of a problem. And I think safety is, if I have a company supplying caregivers, I also care about my caregivers going home, because ultimately their safety, their security is as important, because they are going to do a job which is very, very important. So if they are in a good mental space, then it's good. Another thing I always say is, do not get into any personal kind of sort of misgivings of the caretaker also. The caretaker has to be professional, because it mixes too many things. It is not going to be the caregiver's job, the family's job to take care of the grievances of personal grievances of the caretaker. Because a lot of times the lines are blurred from their side when they ask. So anything of that sort should always be reported, because it's a very professional thing, or else it becomes very, very unprofessional. And I have had cases wherein people have given more money to caregivers because they have asked. and then it becomes very difficult to handle because that is something which was done on the jurisdiction of themselves. So be very professional is very important. But so that they don't get frustrated, I think your behavior towards them is very, very important. They have come to do a very noble job of taking care of your parent, grandparent, your relative. So your behavior and communication to them is very, very important. And you, on day one, have to explain to them properly, like what are the things to be done. They do have they do have training, but that doesn't mean they know that particular person. So routines, things like dislikes. So for example, if loud music you put, she's going to have a problem. So things like that. So then you have to allow them to adjust rather than expecting them to be like, you are a professional, you have to do it anyways, because anybody takes time to adjust to the environment. So your behavior, I think, I mean, the family's behavior matters a lot. And do not blur the line in duties, because ultimately that can be a big issue, because then their attrition levels are very high.
So true. Just a question, follow-up question to that. So, given the situation and how hard this can be, what is the advice that you normally give to people? Is it better to get a 12-hour shift person and have two people in 12-hour shifts, or is it better to have a 24-hour attendant? Because I know that most of the professional care agencies, the home care providers, they prefer to give 24-hour care attendants rather than people in 12-hour shifts, because logistically it doesn't work. But what is your advice on that?
So I usually advise on taking 1 24 hour and training a 12-hour during that time.
Okay.
So the reason is, when that happens, then the 24-hour person obviously gets enough breaks, and at the same time the training period is there. And if at all this 24-hour can go on holiday, then the 12-hour can actually become 24-hour. But I totally agree with you that it's very difficult. A lot of times caregivers are not keen, especially if they are not in the same place or they don't have any place to stay. They are not very keen on 12 hours. Usually, 12 hours becomes very difficult. Why? Because my continuity for the older adult goes. So then it is two different people, and adjustment to those people becomes more difficult for the older adults. So maybe 124 with 12. And to be very frank, I mean, I'm sure we all have had our experiences. Sometimes it is 1 plus 1 is 11. So something else will work, and you might have to split it into 3 8 hours also, or maybe overlap a 12 with it, because one has to make sure, or give both caregivers break, and 2 hours you will have to do. I'm just saying, because ultimately what happens is, the biggest problem that we have family caregivers there is letting go of control, trusting the caregiver. If you are always micromanaging continuously, then that is not, I mean, you're hired somebody, but you're still there. The day you achieve good caregiving from your perspective is when you can say, okay, I am away in a different country, and I'm or a different place, and I'm okay with this professional caregiver taking care of my parent or grandparent or kin. That level of trust to achieve is very, very difficult, but it has happened. It has happened in a couple of my uh, older adults, wherein the family is gone abroad, knowing that we have these caregivers, and with the extra fillip that if anything happens, I will go and see. So that is also something which we have to sort of give that medical backup, so people are more confident.
So wonderfully put, and a very important point that you've put across there. Dr. Banerjee, I wanted to ask you, one of the things which came up in the conversation earlier was that how sometimes the patient themselves may not always trust the caregiver, or they may have some time that they may take to settle down, right? In fact, this is one of the audience questions that we had received, where somebody said how to tackle when a person who's cared for makes wrong or false complaints about a professional caregiver.
Yeah, I think this is a very pertinent question. And, this probably forms one of the challenges or concerns of caregiving, formal caregiving. Many angles are there of this problem. One of which is, let's say there is a caregiver and, someone whom he or she is caring for. Now, why will that particular person not be able to trust the caregiver? Now, it is important to understand, if it is just another illness, age-related illness, there are different factors. In dementia or any form of illness that involves neurodegeneration or problems of the brain, that can be different types of dementia, Parkinson's, etc., stroke. One of the things that happens is, in our technical terms, we call it BPSD, behavioral and psychological symptoms of dementia. So, to put it simply, when the brain reduces in size, which essentially dementia is, it does not just affect memory, understanding, planning, judgment, organization. It also affects behavior. So there are certain things called, as I gave an example earlier, misidentification. Let's say there may be a paranoia that someone is mixing poison in my food. Someone is trying to kill me. Let's say there is a change in caregiver. As Dr. Prem was mentioning, individuals with age and with dementia or cognitive issues, memory issues, they become very sensitive to change. Any change in place, environment, level of noise, level of light, level of social gathering, change in caregivers, change in voice modulation, tone, food, the place that they are in, any single change can trigger a behavioral problem in them. So first, what we need to understand, let's say many times there are complaints like this, that the caregiver is not letting me eat what I want, or let's say they are preventing me from going out. At night, individuals who have dementia, they can often have something which we call as sundowning, behaviors which increase post 5-6 p.m. So since they live in islands of memory from the past, things can be like at 9-10 p.m. or even later in the night, the individual may take things and want to go out, thinking that it's already daytime and they need to go for work. Now, if the caregiver prevents them from going out, then the person may get agitated. So one of the things which is important, for if you are not residing with the person, with your family member for whom you are appointing a caregiver, is to have adequate surveillance. Of course, maintaining rights, dignity, all those things apart, it's important to have a surveillance, because not only to understand what is actually happening, not because you don't trust the caregiver, but also so that you know what is going on if a problem, a conflict, or a legal issue arises. This is a very important area, because when the patient, or let's say if the person even doesn't have an illness, an older individual is not trusting the caregiver, it's very important to understand the context. We often tell that any behavior or any conflict needs to be assessed based on the 3 ABCs. That is, A is the antecedent, that is what happened prior to the problem. B is the behavior, or what exactly was the problem, why don't I trust the person, and C are the consequences. So if I do not trust the person, what did I do to the person, or what that person did to me? As Dr. Prem mentioned, that caregiving is a consistent, dynamic human interaction. Even though in families, we do know the professional boundaries, but if somebody is caregiving for, let's say, any of my family members for years or even months, it is natural in an Indian household, that person becomes kind of a part of the family. So it's not always possible, even though ideally needed, it's not always possible to draw boundaries very rigidly. So when a person kind of becomes a part of the family, knowing where this individual is going, taking them to places, taking them for a walk, any two persons staying consistently, be it a husband, wife, brother, sister, friends, other relationships, or even a caregiver and the person being caregiven for, can develop friction. It's important to understand how much is the friction, where is the friction, whether that is impairing the caregiving. If I am, let's say, as Dr. Prem mentioned, and I'm sure both of you will agree, that caregiving is a tough job. And, it does take a lot of strain, stress on oneself, even if you are being paid for it. So it's important to discuss periodically, as we say, that a review feedback, like initially when you were mentioning that, okay, these things are expected out of you. I often make a similarity or draw a similarity with our internships. When we were MBBS students and we completed and we were in our internships. So first we are said that, okay, these things are expected out of you in a clinic. Of course, we don't know things initially. We get to know them. So periodically, we are often taken together and said that, okay, this is the feedback. These are the areas where you are doing well. These are the areas which needs improvement. And you tell me, are you facing a problem? The same needs to be done periodically with caregivers. They are humans. They have their own problems. And if I overlook and override, or if I am too lenient, problems can happen in both ways. At the same time, it's important to understand the patient's perspective. Let's say I have a brain issue, or I have suffered from stroke, or I have dementia. I am not able to understand what is going on. I am not able to recognize people. Then one fine day, a stranger suddenly comes and tries to remove my clothes, hold my private parts, and tries to wipe them. Which person will not be agitated? I'll be agitated. Any person will be, because I'm not able to identify the person. So process, giving the person time, letting the person get accustomed to the person, and often discussing both with the elderly individual and the caregiver, which we call as ice-breaking session, that where is your problem? What has happened? Because normally, I have seen this, I stay too busy in my work. So my mom, she's the main caregiver who stays with the formal caregiver with my father. So whenever she used to tell me this is an issue, immediately sometimes I used to just counter yell or just admonish the caregiver that what are you doing. But then later I realized that the knee-jerk reaction doesn't solve. You need to sit and you need to understand where exactly is the problem happening. See from the perspective of the patient, see from the perspective of the caregiver, see from the perspective of the primary family caregiver. Bring together these three perspectives. It's a hell of a work, but until and unless we do this, there will be problems continuously arising in the caregiving process.
Thank you for sharing that, Dr. Banerjee. And I just have a question, which I think is important to ask, given that you brought this up. You were speaking about surveillance as being a part of the protocol, if you could, just to kind of cover any legal issues that may come up. So there is a question in the chat room where somebody is asking, is it permissible to have CCTVs? Do you require, the caregiver's knowledge or consent? How does it work?
See, ideally, there isn't any protocol for that. But again, if you are putting anybody under surveillance, it is always important to inform them. I won't say that, let's say my father is there today, there is a caregiver with my father. So I need to ask my caregiver that, can I put a CCTV? Of course, it's my house. I am trusting somebody with it. I'm trusting somebody with my family. I have all the legal and ethical rights to see what is actually happening. But not to mention to that person totally and then putting the person under surveillance can be challenged legally. Okay. So what I would suggest, have CCTV surveillance, particularly, make the CCTV or make the surveillance in a manner where the place or the room where the individual spends their maximum time can be put into care. One can be at the entry point, one can be at the point where the person lives, and inform whoever is there in the caregiving process that there is surveillance, but again, explaining to that person that this is not essentially because I mistrust you, but because it is quite natural that I will keep my house in surveillance so that if there is something both to the patient and to you, I can know that what exactly is happening. And, let's be very honest here. There are a lot of cases of elder abuse. Dementia is a risk factor for that. Safety is a major concern, especially in urban areas. So there is absolutely no second thought to surveillance if there are other family members not present in the house. It's very important for safety. If I am entrusting somebody, of course, I have done a background check, and nowadays there are rules that if you are any trained organization, if they are sending a caregiver to your house, they will send a proper ID proof and address proof. You will verify, and only then will you entrust the person. Because like all fields, aging industry, aging care, dementia care also has the risk of significant fraud, risk of abuse, risk of financial fraud, and one needs to be very careful about this.
Thank you. A very fair and important point. Thank you. Dr. Prem, my next question is to you. This is a question which came up, from a lot of caregivers who had raised this question in the registration form. This is about how can a caregiver deal with the mood tantrums of the cared, which can sometimes be aggression or depression, and how can one stay equanimous in that environment, and while those seniors or older adults are going through their own share of ups and downs? What can a caregiver really do?
So, just to add what Dr. Banerjee also said regarding the CCTV, just a small point. I also sort of am associated with a residential care assisted living facility. So, what usually happens is we have to take consent uh, with the family and then actually put CCTV inside, because that is purely after taking consent. I don't think without taking consent we should be doing it anyways. But a lot of times, what happens in the room, especially, I will quote an example of there was a person in an assisted living facility that I know of who was falling again and again, but the cause of fall was not known and people were not understanding whose fault was it. So, see, in falls, it's a very precarious situation. You need to understand so that it doesn't happen again. So, on video footage, after taking consent, the realization was that no, the older adult himself or herself had actually got up, but at that point, the caregiver should have been there and the caregiver was not there. So ultimately, it was a one-on-one care, but the caregiver had just gone, just out, maybe was called for something else. So obviously, when you do auditing, CCTV becomes a very, very important thing. But it's a very sort of controversial thing, Aaron. Nobody wants to be, have to be looked from an X place. But in a case with dementia, where the decision usually might be the children's and not the person themselves, I think it should be okay. Especially, I have known a lot of families who live abroad, so they want to have that CCTV because that's the only way they can know. And it is not only for keeping a check on caretakers, but it is also for keeping a check on the older adult if they are falling or if there is something needs to be done. Now,
Sorry, if I may ask just to clarify, so when you
yeah,
say you need family consent, this is in the case of when somebody is residing at your assisted living center. Is that the
yeah,
scenario?
yeah,
So,
yeah. That's what I said.
okay.
Because of course caregiving, again here also caregiving is there, but it is given by the professional caregivers that we have.
Yeah, and it's in a
So
professional setting. Yeah.
yeah. And coming back to your question, I think not having a fixed plan is the way a caretaker can take care of an older adult with dementia. If you have a fixed plan, it becomes very difficult, and a dementia person can be very, very different every day. And you don't really know. You might have 5 days of no issues, but on the sixth, seventh day, you might have something, and then maybe nothing for another couple of days. But if there is a behavioral change, there's always a reason. That's what we always say when we are training caregivers, professional caregivers. Why? Is it pain? Is it constipation? Is it that they have been kept in their urine and stool for a longer time? Is it that they have an infection? Is it that they are maybe eating less, so they are more tired, they are more irritable? Is it electrolytes going bad? Is it a hyponatremia? So there are so many factors which actually trigger points. So the caregiver has to understand that there is always a trigger for a behavioral change. You can't just put it only on the disease because it's not always on the disease. Yes, the disease will progress. Unfortunately, it just, a lot of times it can be stagnant for years. And Banerjee will also vouch for this, that we are happy with the plateau. We as geriatricians are happy with the plateau in dementia. If the person is same as how the person was last year, I am happy. If there is no worsening, because the plateau has been maintained. then to have plan B always matters, sometimes to have plan C also. So for example, if you're planning to do an activity with an older adult with dementia and the person is having a very bad mood, now one has to understand how to tackle that. Communication is very important. You can't shout back. You can't argue. You just have to go into the phase and saying, yes, yes, we are not at our home. Arey, but what about eating? So then because of you have to use the forgetfulness is what we train caregivers so that you can get across them. Like for example, they'll be like, if they forget eating, then they'll be like, you're not feeding only. So whenever we take history, we take the relatives' history, we take the caregiver who's taking care of the history, and we also take the older adults. But a lot of time, the older adult is not saying things which might be true also. And this is where elder abuse can be hidden. Because maybe the trigger point is that the professional caregiver has been hitting, or the children might have been hitting, or some way of abuse is happening, and that is the trigger. But there is no way of asking that older adult themselves. So we sometimes go into hints like how the person looks like, is cleanliness maintained or not, is hygiene being maintained? For a male person, is there shaving being done properly or not? So these are the things which then people not turning up for follow-ups. So those are the ones which are again saying online consults actually help to a certain extent with people with older adults with dementia, but not all, because saying that ultimately it has to be a plan which is very flexible. I mean, just having a fixed plan that this are the events we'll do. Routine will help. If you put an older adult into a routine, that's good. But you might have a bad day. So the caregiver has to maybe make a switch and change for that particular time, maybe divert their attention. So those things can be done.
Sure. So, Dr. Banerjee, Dr. Prem specifically spoke about when dealing with people with dementia and their mood tantrums and their, and the changes in their behaviors. How about like some of the questions that we got were where caregivers said, how do I deal with stubborn parents? Or my parents keep fighting with each other, they're squabbling with each other. I don't know what to do about it. Do you have any advice for people who are in that situation?
Yeah, see, I think this is a very common scenario, right? And I assume you are telling this about just older people, like those who do not have dementia,
Yeah.
right? Yeah, so see, again, what we need to understand is every age and every relationship has their own dynamics. Uh, when my grandparents are having a quarrel or having a squabble over something, the best way is not to interfere, because they have their own ways to deal with and how they will settle their own issues, unless it is going to some extent which is interfering with their health. Now, one of the scenarios that becomes a common problem is, let's say, if there is a caregiver for one of the two individuals, and there are issues with between both of them as to about the type of caregiving, or maybe older individuals, they can have an issue when they don't agree on a point, and that uh, leads to missing medications. Sometimes one of them may tend to go out of the house, self neglect. So these situations, of course, need to be dealt on a case to case scenario. There is no one quick one stop solution for this. But if it does not affect their health, if it doesn't affect their social and physical well being, psychological well being, then I don't think that it's important to intervene to that extent. If I have individuals who miss their medicines, or let's say who already have high blood pressure, and this continuous quarrel on interpersonal issues are leading their BP to hike, then we need to probably understand that if there is an environmental issue, if there is an issue with the mood, if there is a problem that didn't happen before and it's happening for the first time now, because another very vital area is, if there are frequent conflicts that are happening which did not happen before, then you need to understand if any of the individuals are under an extreme sort of duress. Is any of them having clinical depression, or are they having any early signs of cognitive issues or cognitive decline or dementia? Because many times the mood, the behavior changes, they start happening way back before any other symptoms start. But that said, not every relationship issue, not every squabble, not every quarrel is related to a medical or a psychiatric illness. It needs to be dealt on a case to case basis, but every subsystem, a couple subsystem, has their own dynamics. So unless there is an extreme need to intervene, we normally do not intervene. Just a point about which Dr. Prem was mentioning. See, a long story short, every 3 seconds, the world has a new diagnosis of dementia. So imagine the burden. Imagine the sheer burden in terms of our population. And, in dementia care, the memories, they, kind of go off, but emotions, they don't. And the caregiver is the person, be it for family or be it assisted, they are the persons who spend maximum time with the person. So the caregiver almost becomes the keeper of their memories. So we always need, whenever there is a problem, we need to look at it from both sides. How frequently, when the person improves or when the person is stable, the family gets credit, the doctor gets credit, modern science gets credit, but how frequently do we really take time to give that recognition, that respect, that credit to the caregivers? Because this is a thankless job. It's almost like you are running a marathon which does not have a finish line. So you need to also give caregivers that recognition. And, they themselves, as I was mentioning in the beginning, we had this discussion earlier as well on the Silver Talkies platform, that if the behavior problems of the individuals are high, be it dementia or not, caregiving becomes a tough job. So caregivers also need to have support groups. Like you mentioned, you run an informal support group. Support groups like this become very important because, when they also understand that others also are facing the same problem, they share their stress, they can learn from each other. That form of de-stressing, that form of learning, that form of debriefing, that can never really, get substituted by just a text or a manual or any form of didactic lecture. And dementia care needs to move to community, particularly in a country like India. So when we talk about a national strategy or when we talk about, a plan, that starts from the family. So as a family, it's very important that whoever has a senior citizen who is being taken care of by a caregiver, be it from the family or a formal paid person, each person has the opportunity to actually learn and set an example of how this model works. And it's not a time-tested single model that will always work. While surveillance is important, trust is equally important. While technicality is important, compassion is important. And this is a journey, this is a dynamics which will keep changing over a period of time. So much so that there are people who literally stop eating if their old caregiver leaves and is replaced by a new one. So that is how important a caregiver is in the life of a person who needs caregiving.
So well said, and thank you for putting the spotlight.
National strategy, and we're really dealing with a huge caregiving burden in the country. Does it, would it make sense for the government? Of course, all these are very idealistic, but like many countries overseas have, to have a carer's allowance. I think Karnataka has something for cerebral palsy because it is also a huge financial burden on so many people. So is that something that would make it, put the focus on the caregiver, at least in a, in a broader scenario, broader context?
Thank you so much, Reshmi, for bringing this up. I think it's a very, very important discussion. We have had several times in policy meetings with governments, with all types of governments. We have had it at local levels, at state levels, national. The problem is, as a country, we lack a national dementia strategy. We recently came up with the National Suicide Prevention Plan and Strategy, which was a huge step. But I'm hopeful all stakeholders are trying. So we really need to have a national strategy which gives very specific importance to the caregivers. I would not just restrict to caregiver allowance. There needs to be appropriate funds, initiatives at all levels to have training of caregivers. Number one, evaluation and a quality certification. It's like the caregiving being a very tender job. There needs to be people who really are experts. And as I said, in various levels of caregiving. Besides allowances, I would also think it makes sense for them to have certain specific leave allowances. If possible, I would even think of it may be an extension, but even think of some tax benefits with relation to their own healthcare, their counseling. Even these things actually need to be a part of the caregiving process. The problem is, again, see, caregiving in dementia stands apart as caregiving from all other domains. Of course, see, caring for a child with autism, for cerebral palsy, for palliative care, for cancers, each have their own challenges. But as I mentioned here, that it takes a lot of emotional, financial, and social toll on caregivers. So I would completely support you. The dialogue needs to increase more and more. We need to have data, because research is something which we can put forward in front of the policymakers. Things are being taking place. There have been a recent discussion at NIMHANS Bangalore itself, and also the Kerala is a very good example for that, because they have almost a state-wise dementia care plan. So we can actually take lessons from this, and whoever, at whichever capacity, we can talk to individuals who are at the policy levels. I'm sure this is something that is going to motivate more and more people into genuine quality caregiving.
Thank you, Dr. Banerjee. I think that's a very pertinent point. I agree. But given that you're short on time, Dr. Prem, I will come to you now. Since we shifted the spotlight on caring for the caregiver, themselves. I think one of the common questions that we got from the audience was about how do I care for myself without being selfish or without coming across as self-oriented? How do I take care of my interests? How do I care of my careers, my social circle? So what is your professional advice to caregivers on this front?
Yeah, so it's a very pertinent question. And one of the very important things is I would say be selfish. I wouldn't say don't be selfish. Because if you're not selfish, then how are you going to get into the zone of taking care of yours? I usually say the motivating factor should be if you are able to take care of yourself, then only you will be able to take care of the other person. Because you will get into stress, you will break down, and you will end up abusing that older adult. Not even physical, you will just give up. I mean, that can happen. People have got caregiver burnouts, then that guilt is forever. So I think it's a very simple thing. I mean, you have to make sure that you have your own time. This is where having good friends matter, having family if somebody near matter. I have had people whose friends were very helpful. They are like, we'll take care of 3 hours, 4 hours, 5 hours. You go out and have watch a movie and maybe come. Now again, the thing that has struck chord with me was what Reshmi ji told very clearly about resources. A lot of families are lucky that they have those resources. Now we have to talk about, whenever we talk about different sort of platforms, maybe even Dementia India Alliance is one platform which we are all associated in some way or the other. What's happening in non-urban areas? What's happening in people who have actually dementia? Caregivers are also the sole breadwinners. How do they take care of themselves at the same time, not lose their jobs or not? I mean, so that is where we have to really get up. Are we able to provide them a solution or not? Again, going extreme. That doesn't mean that if you have the money, if you have the finance, it's very easy for you to actually take care of people with dementia. No, that's also not the case. Everybody has their challenges, but self-care has to start in trying to be not guilty about the fact that no, I watched a movie. Nothing is going to happen. Not being guilty about the fact that no, today I care about my mother, father. It can be brother, sister also. It can be grandparents. But I feel that if I take better care of myself, then I can take better care of them. And let it put it this way: if that older adult has had a call in this, they would tell, "Arey, please take a break. It's okay," because they have always cared for us. So we are only sort of trying to give them that extra care. And that's where, I mean, this comes in a lot of, I mean, I can say from my experience, the guilt that comes to a lot of people, maybe guilt, maybe that stigma that why should we put older adult with dementia in an assisted living facility? I say the other way. If you know that there can be better care taken, then you're doing a disservice. Because you know you have done everything possible. So we will go back to the quote which we always say. I think women are always superhuman, but in general, we have to understand our limitations. If a caregiver can understand limitations, the battle is won. You should always, and older adults do this very, very rarely in seeking help because they feel if I was okay 1 year ago, then I should be okay now. No, your body has aged 1 year more. The reason I'm saying older adults because we have older adult caregivers also. Let's not forget that we have plenty of them and they might be number one caregiver and then children are. Then there is also types of caregiving. So from an older adult perspective, if your son, your daughter is not able to come and they are still providing some financial aid some way, they are still caring for you. Remember, it's just that they are not able to come in person. A lot of times families have different people doing different things. The person who is local is actually going and doing everything, but partly maybe financially somebody else takes care. I think that is something you should leave to your children how they want to do it. But everybody cares. That's what I'm saying. And if you're able to take care of yourself, then you will be able to take care of anybody. And lastly, but not the least, I hope, I mean, we have been talking policy, if we can somehow help caregivers, because it's a crisis for making sure that the caregivers who are now professional, non-professional, family, burnout is very high. And we also need to create more. Remember, everybody is only going to get older. With medical care improving, I mean, of course, if anti-aging goes over the roof, also people will live long. People are not necessarily going to just go maybe 20 years, 30, 40 years. That's already happening. A 70-year-old looks like a 50-year-old now. That's not something which is not already happening. So the age has nothing to do with how you are physically, mentally, and socially. And always, as a caregiver, join support groups, seek correct knowledge. Do not take your own knowledge. AI, see, I will give you a very good example of what AI is good and bad. Now, with AI coming up, I'll give an analogy of if you see an MRF bat, then you have two names which come to you, Sachin Tendulkar and Virat Kohli. Now, if you give an MRF bat to a number 11 batsman, the bat is not going to help. So what I'm trying to say is the right person using AI is very good. So you have to have knowledge, but ask pertinent questions to AI. Take help from your healthcare professionals to get better knowledge. Do not depend only on Google and AI. There have been a lot of instances already where a direct advice have been unnecessarily followed. Remember, AI gives answers to the way you direct it. It's not going to give you the right answer because it is right or wrong. So make sure that you always get knowledge from trusted sources. I think it's very important. Why? Because older adults are unfortunately guilty of absolutely forwarding the maximum WhatsApp forward. And that is unfortunate, but it's true. And with your experience and wisdom, I would expect you to make sure that that's true. and then you send it across. So I think that's what we should do. Strive to get better knowledge, but not at the cost of harm.
Thank you. As I'm sure you have struck a chord with the audience in here. Rush, I want you to bring in your perspective as a caregiver, and what practical steps did you take to take care of yourself? How did you build in a care system for yourself?
I don't know if I'm the right person, but one, I think because there are so many senior caregivers here, I guess, I think I was pretty much younger, and yeah, resources. And also the fact that I'm also a mother, I work as a freelance journalist. So there were other areas which demanded my attention. uh, Parenting, you can't say no to parenting. It will always demand your attention. And I have teenage children. And, I did want to, look at my journalism career also. So I think those two things helped a lot, and great friends. But but I think it would be great. There are, I mean, we can ask later if we have time. There are a lot of senior caregivers here whom, I mean, I can't even fathom the challenges they would have had.
Yeah, okay, thank you. Dr. Banerjee, while we are on this topic, and since burnout was something which was mentioned, what is caregiver burnout, and what are the signs that that a caregiver needs to look out for to recognize it, and what should one do?
Yeah, so see, as I mentioned earlier as well, that since it's a continuous process, often considered to be a thankless job, and burnout specifically comes in where the scope of improvement with care is less. As Dr. Prem was mentioning, that even if an individual is stable with care, even that's a success. If there is an improvement, that's a bonus. But we always cannot, in dementia at least, I have to expect the worst to happen. So when over a period of time, caregiving really takes a physical, a psychological, and social toll on the caregiver, that's burnout. I mean, burnout quite literally means that you are almost done caregiving. So it's why it's important, because we discuss a lot about the medical issues pertaining to dementia care or senior citizen care. But when I talk about person-centered care, that's what's very important. Right now, I am presently working as a commissioner for the Lancet on the same person-centered care for older people. What primarily the focus internationally is that you need to take care of the person who are caring, because they are the main custodians of the health of the individual. So burnout is often identified as when you need to push your limit to do the job. It's like you are straining yourself. Again, I have to go, I have to be there, I don't feel like, somehow I just have to do because it's either my duty or I'm paid for it. This thought is the first thought to come. Headaches, physical complaints like body pains, easy irritation, losing temper and losing patience, feeling low, feeling anxious, reduction in appetite, reduction in sleep, the thoughts of caregiving continuously moving past even when you are not in the caregiving process, and the continuous sense of letting go, that enough ho gaya, mujhse nahi ho payega. So this is the thing that actually indicates burnout. And why is it important to identify the areas of burnout? Because many of us, and I will again give a personal anecdote to this, many of us, even though we feel, and I'm sure Reshmi will agree on this with me, that we understand, but we think that, oh, it's normal, so just let's push and see, it will go away sometime. It doesn't. And again, caregiving is not burnout is not an illness. It's not depression. It's not an anxiety disorder. It's a part and parcel. If you carry a very heavy boulder on your back, at one point of time, your neck will pain. And either you need to give it to some other person to carry for a while you rest your shoulder and take it back, or you need to keep it on your other shoulder, or you need to change the position, or you need to keep an aid so that you can put it on that so that you feel less strain. So these are things which you need to adapt if you are feeling burnout. Respite is important. Support groups are important. trying to have some time off for yourself so that another person can take care is important. Sharing is important. And most importantly, if you are feeling that things are going beyond the limit, it's affecting your personal, professional life, your diet, your appetite, your sleep, your body weight, please seek professional help. There are many individuals who come and consult us, not just for caregiving, but also for their own mental health care. And neglecting will only affect the health of your patient. You are not doing them a favor by neglecting your burnout. You are doing a distress both to yourself and the person you are caring for. And thank you for bringing this topic of burnout, because without this, any discussion on caregiving is incomplete.
So true, so true. And, as Lakshmi mentioned, many a times caregivers do not even recognize that they are undergoing a burnout. And I think that's a very difficult one to handle. And I think what you mentioned earlier about having, being part of caregiver support groups where you can lean in into somebody, or having a friend circle which will help you out, is going to be very important. Dr. Prem, I'm going to ask you
Something called,
yeah.
I'm sorry, Nidhi, just,
Yeah.
there is something called, not something, I mean, this happens to all of us. Whenever we are in this position, there is always this point of denial, this why me? And that can really be addressed when you are in a support group.
Surely.
The sharing of distress, no matter how simple it seems, gives a huge relief. And I'm not telling this as a doctor, I'm telling this as a caregiver myself. So it's not that we don't identify burnout, we often identify it, but we tend to neglect it. And that's very harmful.
Yeah, and I think knowing that knowledge that I am not alone in this journey, there are many others. I think that itself takes away a
It's a
lot of
huge
burden
difference.
and that lot of frustration. That's so true. Dr. Prem, I think I'm going to end the conversation with this one question. We spoke about the gender disparity in caregiving and how women end up being the default caregivers. And this is a question: how can we train men to be equal participants? What is it that you would like to tell the men in the group and those who would listen to this conversation later? How can we make them more accountable and responsible towards caregiving? A
Okay, so
tough
I get
one.
the
And I think
difficult
I can get
question.
Dr. Banerjee also on this, but I'll ask you first.
Okay, so I think, I mean, a lot of times, I would still say that it's not, I mean, data never lies, but a lot of times, unfortunately, even if you're talking about the spouse, the male is actually not even alive. And I'm just saying it usually, if you see any disease
Women tend to
happens,
outlive.
women tend to live, women tend to live longer. And that is what creates a lot of crisis for a person taking. Now, again, I mean, I think it's just that it's been happening. It's not that something people have wanted to do about it. It's just that it's been happening. And I mean, I would say, if you say personally, I mean, I am the one who actually takes care of the in-laws side health part also, and I also take care of my mom, dad also. But of course, being a doctor, I think maybe it just comes in and we are asked the questions. I would say maybe they should be asking my wife also a questions, because my wife is also a doctor. And she is asked, but ultimately maybe we both. So I think there has to be a case where maybe I won't say maybe only men have to do it. That's not what even women are saying. I think women are saying it should be shared. It should be more amount. In fact, a lot of times it's not even that. It's about understanding the amount of care that the person is doing. So now, I'm just giving, if somebody has to go for a movie and that the female wants to do it. So the minimum that a husband, or maybe even any male, I'm not even saying husband, brother, why not a brother, can do is actually just maybe stay over at home. So in fact, I know of a family who does this also. They have not changed the home, obviously, because it's a dementia person. So you can't change the resident's home, because then it is going to be too much of disorientation. So brothers and sisters divide days. They do 15 days. The home is not changing. So in this way, what is happening? Of course, this is in Bombay, so it's easier. It's not different cities, but they're actually doing, and they're working too. So it's basically, of course, your line of work matters a lot. So for example, both of them are working from home. So it becomes a bit more easier. Maybe I'm not saying it's easier. According to me, work in home actually blurred lines during the pandemic, wherein older adults thought that children will spend more time but they didn't realize that actually they were still working. They were still working till 8, 9. People who are having timings abroad was even worse because they were working well through the night. Because there was no restriction, there were no rules technically. You could actually, talk till any time. I would say we as the male gender has to take up more responsibility. I don't think it can be just naturally coming onto females. It's just that it's happened. So we have to change that narrative. I think a very good advertisement that came recently, I'll just do a cricket analogy, is that there's the Women's World Cup coming. So the jerseys which are usually sold are only of men for no real reason to verify. But the ad was, if Smriti Mandana plays for India and Virat Kohli does, both are playing for India technically. So if the Indian cricket team wins, it's the Indian cricket team. It shouldn't matter whether it's the male or the female. So I think we obviously have to open our brains and senses to actually understand that we have to support. Nobody's asking us to do it entirely. A person is just asking for breaks. And a lot of times, unfortunately, the realization is also not there because it's just in their own world. To replace is not what women want, to substantiate and to add. A lot of times I feel even asking, how was your day, should be a great thing. You cannot just say, "Nahi, it's your mother or it's your mother-in-law, it's your father-in-law." You should be sort of doing that. Again, the change of behavior should also be from the older adult perspective as well. A lot of times expectation is because it's tradition or because it's happened that the daughter-in-law only has to care and not necessarily the son. The son is working. So, there are a lot of taboos which we have to burst. There are a lot of bubbles we have to burst. Ultimately, it has to be equal and can be split too. And why not? Because ultimately, both care, according to me, equally for that older person, but that care has to be shown in hours. It cannot just be in verbal on how that older adult is or how or just to be maybe just, I know a lot of caretakers who come during admission only. I don't see them ever. So that also happens, and that is pure guilt according to me. There is no other thing that we were not there and things happen. So I think education and breaking barriers is the only way we can go ahead, and having more and more forums like this, or else it's never going to, if traditions are followed, you can say blindly, so many have been followed for years together. So that will just continue. And I think we as healthcare providers also should initiate conversations on it and get people in different platforms to talk about it. Just talking data and saying maximum are older caregivers are females is not going to be helpful.
True. Dr. Banerjee, do you have any silver bullets? How women can get more support from men in caregiving?
Yeah, I guess we have already overshot time, so I'll try to
Yes.
keep it very brief. Yeah, I think Dr. Prem has mentioned the crux of it. I would just put it this way. See, it's about how the society perceives gender roles. To put it very simply, it's still the traditional misconception that women cook better and women are meant for cooking or they're meant for organizing homes better than men. It's like, but on the other hand, we often know that men are often the best cooks. But now it's like this, it's assumed, be it in research, be it experience, I'm sure many of you will agree here. It is often assumed that women will be better caregivers because their ability or their compassion empathy ratio or ability to empathize is probably more. I'm leaving probably because, again, it's a debatable thing. But it's also important to realize that there are enough male caregivers who exist. I know about many individuals who care for their sisters, for their grandparents, for their spouses. I can never imagine. So, it's important to understand that, like all aspects, caregiving is also something which certain things, certain domains are probably dealt with women better, certain domains are dealt with male better. For example, if there is a logistic, if there is a support, if there are mobility requirements, you can well understand that somebody with raw muscular power will be more essential. Whereas on the other hand, if you need to probably cognitively or compassionately engage somebody, I'm not telling a man cannot, but in certain cases, probably a woman will be better in such cases. Now, always we will not get a 1:1 matched care. But like we train caregivers, I think even in training, even in appointing, even in terms of benefits, policy initiatives, there needs to be a gender matching as much as possible in caregivers. The other important aspect is, and let me take, it's like almost like a devil's advocate, the other angle. I was talking about burnout, right? We often know that males, because of the societal perception or that typical example of mard ko dard nahi hota phenotype, they feel that they can bear anything and everything. So help seeking when they feel burnout is much lesser in males compared to females. So that's another important area. They tend to exhaust themselves because if, let's say, very naturally, if somebody comes and tells me that, I am caregiving, but I am not feeling psychologically fine, the common advice that they get is either take a puff of cigarette or go and have a drink, or why are you crying like, typically, quote unquote, why are you crying like a lady? And this is a societal imbibing of certain harmful ideas which have transgenerationally passed on till date. It needs a separate webinar. But how we can break this? Probably forums like this, dialogues, talking to them, letting them also vent out their feelings, and maintaining sharing of responsibilities among gender in the same family. So there is nobody, as Dr. Prem mentioned, that everybody is a caregiver in their own way. So there is no a bigger, greater caregiver and a lesser caregiver. Whatever you can, in whichever capacity, do it. The
Wonderfully
more you
put.
share, the more it is better for everybody.
You have any parting words while we wind up? Anything that worked for you that we haven't spoken about, which you would like to give away to any caregivers in the house right now?
I think I put that in chat, and what both the doctors said, Dr. Debanjan mentioned, sharing. I think being part of a support group initially, it's our own Silver Talkies support groups that Nidhi spoke about. Especially the dementia support group. Many of you here are part of it also. It's really, it helps to know that you're not the only one dealing with, say, certain situations, whether it's medication, whether it's a certain kind of behavior. So yes, that helped a lot. And also having very good non-judgmental spaces, whether they're friendships or whether, in my case, those were friendships, but you can also have support groups which are like that, and they are available online also.
That's a great note to leave with everyone. So your question right now, we are really bad, going very bad on time today. So thank you so much, Dr. Banerjee. Thank you, Dr. Prem, and thank you, Reshmi, for joining us. And